Thank you very much. It's a real big honor for us to be here, so I appreciate the invitation. Lisa and I are going to talk about 3 kinds of science communication using the example of prescription drugs. First, commercial communication in the form of direct-to-consumer drug advertising, public communication in the form of FDA approval documents, and then a new approach that we developed called the drug facts box. So science communication matters because it gets people the facts they need to make good decisions. Thanks. But in the past, people were not always the intended audience for drug facts. In fact, it was illegal. This is a FDA regulation. It says information in drug labels should appear only in such medical terms as are not likely to be understood by the ordinary individual. Okay. Now, this is not a typo. This is the actual, from when the modern FDA was originally set up in 1938. So it was a different time, a very paternalistic era, and things have changed, but that was the original regulation. So things have changed, of course, and now consumers are the intended audience for lots of drug information, most prominently in the form of direct-to-consumer drug advertising, which is an industry that's taken off in the past 2 decades. The investment in direct-to-consumer advertising has gone up dramatically. It's now at about $4.3 billion a year. For some context, that's about 10 times FDA's total budget for evaluating new drugs. So what do you get for $4 billion? Well, you get stuff like this. This is Joan London. She used to be the hostess of Good Morning America, and she's talking about Claritin. I tried 1 million different kinds of over-the-counter antihistamines. They made me feel drowsy. Then my doctor prescribed non-drowsy Claritin. Works for me. So this is an assertion of benefit, but there's no data. You have no idea how well the drug works. This ad also has an assertion, not by a celebrity, but by a nice lady in her garden with a hat. And it says, "Now I finally have my blood sugar under control." Now this is a much more sophisticated ad than the other one, and I'm glad we're at the National Academies of Science because they have, there's a cell, and it's got all those red dots around it, but then you give the patient Resolin, and as you can see, the dots all line up, and there's an R that appears in the middle of the cell. So they don't really have to say anything else, but they do. They actually give some data. They say more than 1 million people have begun using Resolin to manage their diabetes, which of course is interesting, but that's data about popularity. Again, nothing about benefit. And if you know this drug, you know that shortly after this ad campaign ran, it was pulled from the market because of fatal hepatotoxicity. So this is how the ad now reads. 1 million people have stopped using it. Now here's an ad that actually gives data on how well the drug works. It's for Lipitor, one of the highest selling drugs in the history of the world. And it says, "Stroke, Lipitor cuts the risk by nearly half," which sounds great. Right? We all want to cut our stroke risk in half. Of course, you don't know if this is great, right? Because you don't know half of what. So this is a classic example, the oldest trick in the book, where you present a relative risk reduction cut by half without giving the base rate, of half of what part. So this magnifies small effects. So if you looked for the actual data, you wouldn't find it in the ad, but if you track down the article that the ad's based on, you would find that Lipitor reduced the chance of stroke over 4 years from about 2.8% to about 1.5%. Now you may think that's big or small, but the point is it's your decision. You have to use the data in the prism of your own values, and you can't do that when you get the other form of data, the relative risk reduction. You need to see the actual event rates. So it matters how you say things, right? This is the framing effect. 50% reduction sounds much more impressive than 1.3 percentage point reduction. The first helps you sell drugs. The second might help people make informed decisions. So this is exaggerated data. Now, if you look at drug ads, you always notice print ads, the second page is the brief summary. This is a misnomer because it's not brief, it's not a summary, and it's got tons of information about side effects only. There's data about side effects. There's nothing about benefit, right? And it's so small you can't even read it anyway. So this is really non-communication. Now, I've shown you selected examples, but Lisa and I have looked at this systematically. We did a paper looking at how drugs are advertised in popular magazines, and we found that what I've been telling you about is the rule, not the exception. Benefits asserted with vague qualitative statements. Only about 13% of Advertisements included data, and when they did, it was in the form like the Lipitor ad, in a typically an exaggerated format. So that's commercial data, direct-to-consumer advertising. It's appealing, it's fun, it seems easy to understand, but it can be very misleading. Now let's look at public communication, FDA approval documents. Now, FDA approval documents tell you what FDA knew at the time of drug approval. They're the best record of what they knew. When you when you have a new drug and you want it on the market, you send in a new drug application. And then FDA staffers spend a lot of time in different disciplines reviewing the evidence and writing reports called reviews, giving their take on how well the drug works. Sometimes they'll convene external reviewers as well, advisory boards under certain circumstances. This information is a gold mine. And amazingly, it's available for free on the FDA's website at Drugs at FDA. So the best way to get to know how well the drug works, if you have the time, is to look here. And you can know what FDA knew at the time of approval. The website looks like this. You just put in the name of the drug. This is Lunesta. It's a sleeping pill that Lisa and I have tangled with in the past. And if you go to the drug approval package, you can pick out one of the reviews. We usually look at the medical reviews or the statistical reviews. You just click on it and you get the document. It's wonderful. In this case, the document is pretty big, and this is typical. It's 403 pages. And the bad news is they're poorly organized, weakly summarized. They're a real bear to get through. But if you can, they're a gold mine. There's no other way to really get to know what FDA's take on how well the drug works than by looking through these documents. So what's the fate of the information generated in this approval period? Well, you start sort of below the waterline of these thousands of pages of FDA review documents written by these independent FDA reviewers. But the public face of this, what gets out, is actually the FDA-approved label. This is the tissue package paper insert that comes with all prescription drugs. It tells prescribers how and why to use the drug, and it's the source of all advertising claims. But this isn't written by independent FDA reviewers. This is written by the pharmaceutical company. And then this information is further distilled into the ads, and only a small piece of this information makes it into the ad or into the brief summary. And again, this is done by the drug companies. And there's a tremendous loss of information as you move along this process, and a lot of selection of information as you move along the process. So that's, the fly is back, amazing. So those are the FDA approval documents. They are dense, frustrating, but really useful. So Lisa and I thought, well, wouldn't it be nice if you could come up with a better way? And we developed the drug facts box. And the idea is simple, something that's appealing and easy and useful, but not misleading, frustrating, or dense. So how do you do that? Well, we thought about it a lot, and one day the answer came to us over breakfast. But we're married to each other, by the way. So, and so we're having our breakfast and our Cocoa Krispies, and Lisa turned the box, and we're like, whoa, it's the nutrition facts box. And we thought, wow, this is a great example of where we're an agency, tries to give information to consumers to help guide their choices. It gives them data in a table. Now, you can quibble with what's in the table. We like just the idea. And we thought, if you can do this for Cocoa Krispies, why can't you do this for Lipitor? Not tell us the ingredients and the calories, but how well the drug works and what the important harms are. And to cut to the chase, this is what it looks like. It's a one-page document. Lisa's going to talk about it in a little detail, but I just want to say that the heart of the box is this table. Simple tabular display of benefit and side effect data. So we were really excited about this, and we kind of had like a Mr. Smith Goes to Washington fantasy that we would go to the FDA, and we'd tell them, the labels are a mess, the ads are a mess, and we'd show them the box, and it would, immediately start happening. And in fact, we actually did contact FDA, and to our amazement, we were invited down, and we had a meeting. This is back in 2002. We met with 20 FDA officials. We presented our idea, and they liked it, which was great. But they said it would take an act of Congress to get boxes on ads. And then the most interesting thing, they reminded us that FDA is always focused on harms, on side effects. And what was amazing is the idea of presenting benefits to consumers, telling them how well the drug works, was something that was really new to them. And they challenged us to show that, this is serious, they challenged us to show that consumers want value and understand benefit data. So we left the meeting very excited, and we decided we're going to do just that. So we launched a series of studies. And the first one I'm going to tell you about is the Boston study. We were just testing the benefit portion of the box because that's what FDA was challenged us to do. This was an interviewer study. We had 203 people recruited in the greater Boston area. Had interviewers knocking on doors, not just around Harvard and MIT, but also other parts of Boston. So this, and the interviewer oriented people to the box and had people do simple comprehension tasks to show that they could use the information and understand it, and asked them how they liked it after they were familiar with it. And overwhelmingly, people liked it. 93% of the participants preferred ads with drug facts boxes compared to the same ad with just a standard brief summary. So that was very encouraging. Then we did a larger study. It's called the Vermont study. Here we created a drug box for the drug Novodex or tamoxifen, which is used for the primary prevention of breast cancer. And here we had 274 people in the study. They were given a more complex box, so a table with 9 rows and 2 columns of data on both benefits and side effects. So this is a complete drug box. And there was no interviewer, no instructions, no training on how to use the box. They were just given it and asked a bunch of questions and asked them to do some demanding tasks, navigating the box, comparing numbers, and that sort of thing. And what we found was that people not only liked the box and were able to use it, but they did quite well. On average, they got 4 to 5 data comprehension questions correct. For people with lower educational attainment, less than high school education or high school education, we got very similar results. So we were, again, very encouraged. Then we launched our gold standard study, a national randomized trial. This was a study of 231 people recruited through random digit dialing. And it was a real-world challenge. We showed people ads for 2 drugs treating the same condition, heartburn. And we used real ads. And the drugs were chosen so they would have similar side effects, but one was substantially more effective. So there was an objectively better drug. And the question is, could people choose the better drug? People in the control group were randomized to get the ad. And again, these are the real ads. The only thing we changed were the identifying names and the manufacturer. We used a modified Pig Latin algorithm, which we can share with you later. But, and then the people in the, and then of course, because, as is sadly the case, there's no benefit data and just a laundry list of side effects. The drug box group got the same ad, but instead of the brief summary, they got a drug box, which, as you now know, contains benefit data and data on key side effects. And the primary outcome measure of the study was if you could take either drug for free, which would you rather take? In the control group, 31% of people chose the objectively better drug, but in the drug box group, more than twice, 68% chose the objectively better drug. So that was very impressive because it's a difficult task. So bottom line, consumers want and can understand the drug facts box.
Then we had the opportunity to present, it's on. Can you hear me? Yeah. Okay, sorry. To present our work at a combined Institute of Medicine and FDA workshop on improving the communication of information about prescription drugs. And the IOM panel challenged us to create a box for Zometa, a drug which was chosen by the FDA member of the panel. So to create the box, we went to the FDA approval documents, as Steve told you, the best source of information about how well drugs worked, and we looked up Zometa. So what I want to remind you is that the purpose of the box is to help explain what FDA knows about the drug at the time of approval. What I'm going to show you is how we filled in the box, what we chose to include in the box, and why. So the first section of the box is a narrative section, which starts off about what this drug is for. And we have a rule, which is that each box is not just for one drug, but for one use of one drug. So if a drug had multiple uses, it would have multiple boxes, okay? So in this case, this box is for Zometa to treat cancer-related high calcium, okay? But this drug has other uses. The other narrative sections of the box are who might consider taking it, what should I be aware of, and what other choices are there. Now we get to the heart of the box, which is the main phase 3 trials that are the basis of FDA approval. In this case, the FDA combined the two studies that were done into a single analysis. So there were 275 people with cancer and high calcium who were given either Zometa or Iridia, and here's what happened. This was a 3-arm trial, so people were randomized to either Iridia, which was the standard treatment at the time for this condition, or Zometa 4 milligrams, or Zometa 8 milligrams. Now, drugs can have different effects on different kinds of outcomes, and we sort of organize these into 3 categories. The first outcome is surrogate outcomes, which are things like x-rays or blood tests. The next general category of outcomes are patient outcomes, things that patients directly feel, like getting better or having a heart attack. And then, unfortunately, death, the ultimate outcome, which we all hope to avoid. In this case, the primary outcome of the study was a surrogate outcome, and it was how many people had their calcium lowered below a pre-specified threshold at 2 weeks. And it turns out in the Iridia group, 70% of people met the threshold. In the 4 milligram group of Zometa, 88% met that threshold. And in the 8 milligram group, 87% met that threshold. So both of the Zometa doses seem to work equally well and better than Iridia. Now, the study didn't measure patient outcomes. We include this in the box because sometimes it's really important to know what we don't know. So we don't know if Zometa creates any improvement in terms of how people feel. But the study did report on death, deaths from all causes at 8 weeks, which was 19% in the Iridia group, 19% in the 4 milligram Zometa group, but nearly double in the 8 milligram group. Somewhat disturbing. I doubt anyone wants to take the 8 milligram dose here. I know I don't. The way that we know about the death data was because we read the statistical review, and the data on all-cause death is in the statistical review, and in the statistical reviewer's conclusion, he wrote both doses, 4 milligrams and 8 milligrams, satisfied the protocol mentioned criterion, so lowering calcium, and then he said the 8 milligram dose had a somewhat higher death rate. So it works, but it might kill you. Okay. So for this reason and other reasons, the FDA chose to only approve the 4 milligram dose of Zometa for this indication. So in the box, we wouldn't present a column of the data on the 8 milligram dose, but we would include a very prominent warning, right? Because once a drug is approved, doctors can use it at any dose. So what we would say is, do not use an 8 milligram dose of Zometa. Phase 3 clinical trials have shown that the 8 milligram dose is no more effective at reducing calcium than the 4 milligram dose. But that's not what happened. Here is the original FDA-approved label. So at the time of approval, this is the information for doctors about the use of this drug. It says no additional benefit was seen for 4 milligrams over 8 milligrams. However, the risk of renal toxicity for 8 milligrams was significantly greater than that seen with 4 milligrams. So does anyone here think that renal toxicity and death are the same thing? Okay. So the data on death aren't anywhere in the label. The other place that doctors get information is from published journal articles, and this is an image of the journal article that was published about this very study. And not only does this article not include a warning about the 8 milligram dose, in the abstract of the article, it concludes by saying 4 milligrams is the dose recommended for the initial treatment, and they recommend 8 milligram for relapse or refractory hypercalcemia. And in fact, the death data are not reported, shockingly, anywhere in the article. This is the published report of this study. The other important part of the box is about side effects, which side effects are important. And here the issue is data overload, laundry list. So if you look in the label, what you'll see is that there are side effects. Some of them are presented in text, some of them are presented in tables, and they're just not organized in any clear way. And so it's really hard, I think, for doctors and patients to know which side effects are really important. In the box, we've tried to address this problem by organizing side effects into a hierarchy. So presenting, come on. The clicker, into life-threatening side effects and symptom side effects. And then the next thing was we needed a decision rule to display a reasonable number of side effects, so we could limit the list to the most important side effects. So our rule was to include all life-threatening side effects and the symptom side effects that had the biggest absolute difference between the comparison group. And when we applied this rule, we ended up with a manageable number of 6 side effects. And voila, this is what our full box looked like. So when building boxes, we've come to learn that you need to have explicit rules, not just about side effects, but of all the elements in the box to make the content and format of the boxes transparent and replicable. And in fact, we have a handbook, which is a document of decision rules, and we started this handbook when we had a pilot project with real-life FDA medical reviewers, and then we have subsequently iterated this decision, the handbook, many times, and have subjected it to peer review by experts outside of FDA. We also learned that building boxes showed us that there's lots of important information known to FDA that never gets to doctors and patients, and it's not just unique to the Zometa label. This is a perspective that we wrote in the New England Journal, which highlights 3 examples where FDA drug information never reaches clinician. This article talks about Zometa and 2 other drugs. The first is Lunesta. This is the direct-to-consumer ad. It is a very heavily advertised drug, which you may have seen the ad for. And in the ad, it says Lunesta not only helps more people fall asleep fast, it helps you sleep all through the night. Now, of course, we're not surprised to just see benefit asserted without any data in the ad, but we were really surprised to find that when you look at the label, the information for doctors, it looks pretty much the same. Lunesta was superior to placebo on subjective measures of sleep latency, total sleep time, and wake time after sleep onset. So nowhere in the label can the doctor learn how much it works. They can just learn it works. So when you slog through the FDA documents, you can find out, oh please, all right, how well it works. This is the result from the longest, this was a 6-month study and largest phase 3 trial. And what it turns out was the Lunesta helped people to fall asleep 15 minutes faster and sleep 37 minutes longer. But even with the drug, the average time that people slept was only 6 hours and 22 minutes, which means they still would have met the criteria for chronic insomnia that you needed to get into this study. So nobody was in fact sleeping the average person on the drug is not sleeping all through the night or 8 hours. Rosarum is a second example which highlights the idea of missing uncertainty. So this is what the label said. Both doses of Rosarum reduced the average latency to persistent sleep at each time point when compared to placebo. No uncertainty there. When you look at there were a number of trials. There were 2 sleep lab trials where people fell asleep either 7 minutes or 14 minutes faster. 2 outpatient trials, one where the drug didn't work at all, the second where people fell asleep 8 minutes faster. But they measured a host of secondary outcomes, and it turns out that on all of these outcomes, the drug did not work on any of them. Whether the physician thought the patient was any better in terms of their insomnia, whether the patient felt that getting back to sleep was easier, the number of sleep awakenings, the total sleep time, or their sleep quality, none of these things got better with the drug. So you may be wondering, does this drug really work? And in fact, the medical reviewer was worried about whether it worked. And this is what he wrote. Rosarum has a statistically significant treatment effect that is of a marginal clinical significance. The treatment effect does not seem robust. It fails to demonstrate a treatment effect in the subjective efficacy parameters. The drug company had argued that Rosarum's unique mechanism of action makes it difficult for patients to appreciate the shortened time to fall asleep and the increased total sleep time provided. But fortunately, the medical reviewer saw right through this, and he said patients who are currently being targeted by the proposed indication do not seem to recognize any benefit from treatment with Rosarum, but nonetheless, it was approved. So The next lesson is including drug boxes in the label would help ensure that what FDA knows about benefits, harms, and uncertainties gets communicated. Now, we hope you'll agree with us that the drug box is a nice idea, and you may be wondering, well, what happened? Well, one thing that happened was we presented our work to the FDA Risk Communication Advisory Committee, and they made a recommendation, and that was when it was chaired by Baruch Fishoff, and they recommended that the drug facts box become the standard for FDA, all of FDA's communications. I should get an extra minute for the delay on the, all right, so I only have 2 more slides. So we finally got, and in fact, that generated, the word got out about the box because the New York Times reported on our research and the FDA recommendation, and we finally got our Act of Congress, Section 3507, and here you can see President Obama signing the health reform bill. Oh, please. Okay. Wait, I'm sorry. The story seems like it's going to have a really good ending, but in fact, what the law said was that Congress had to, that the FDA had to report to Congress in 1 year and say whether they were going to move forward. And then this is our next slide, our last slide. Oops. And it turns out that in the report to Congress, they said it would take them 3 to 5 more years to make any kind of decision about whether to move forward. And that's what we talked about in this op-ed that we wrote in the New York Times last summer. And I'm just going to end with our most important lesson, which is getting more science into communication is one thing, but getting science communication implemented is another. Thank you very much.